So if the opening statement is this child having pain during his walking, sometimes there may be not so much of prominent pain, but during walking only, there will be whenever the child is returning from the school, there may be some pain. So this kind of opening statement may be there. So a tall child with some feature which is like long faces and some other features like facial features which is syndromic. So we'll go for the examination which is called Bayton scoring. So this scoring system we need to do, and after that general examination. Okay. So here what we'll do in Bayton scoring, that is very important. We need to do, otherwise then the examination will be incomplete examination. So first we need to ask the child to bend the little finger in opposite direction. If this is more than 90 degrees, if the finger is moving more than 90 degrees, then definitely the child having hypermobile joint and bilaterally. Okay. So here what will happen bilaterally? So each finger one mark, one score. So this is right hand 1, left hand 1, and again we'll ask the child to touch the thumb in the flexor surface. Okay, flexor surface of the arm. So again both the hand with the thumb, then 1 and 1. Okay. Now if we move little downward, then at the knee, at the level of knee, if there is any kind of hyperextension at the level of knee joint, definitely that will be scored like just like bilaterally, but in the right side 1, left side 1. Okay, that is more than 10 degrees. It's positive for Bayton scoring. Okay, so if the Bayton scoring is like just like here, right side and left side 1, 1. Okay, and lastly we'll ask the child to touch the floor. We'll ask the child to touch the floor, and that will be easily. So in normal individual that will be difficult to touch the floor easily. But if the child having hypermobile joint, that will be easy. That will be easy to touch the floor. Okay, to keep the knee joint in a straight position. So that is giving our one score. Okay. So if we just add all these points, so suppose this is the little finger, both the side, and this is the thumb. Okay, this is the thumb. Now here 1 point and bilaterally, so total here 2 points, here 2 points, and at the level of elbow joint 2 point and 2 point, at the level of knee joint 2.2 bilaterally. And at the if the child is bending forward easily, that is 1. So total score is, I think it's 9, right? So this scoring system is very much important. So 2 plus 2, 4, yeah, total 9. Okay, total 9. Now the Bayton scoring, if is more than 4, then the child is possible of having hypermobile joint. This is the scoring system we need to do in our examination to fit into the diagnosis. That means we need to assess the child in format of hypermobile joint. Okay, in hypermobile joint, and after that, if the child is having more than 4 in scoring system, then we can say the child have hypermobile joint. So we need to remember each and every step. So this is important. So, and easy to remember. As you can see in the little finger bilaterally, thumb bilaterally. Okay, then elbow both the side, knee both the side, and touch the floor, just like checking the spine, scoliosis. Okay, so here in this movement, the child will be easily touching the floor. So this is the score, and that is very much important in hypermobile joint. Hypermobile joint in the examination is very common exam scenario. So that can be given. So this score we need to do in the exam. Okay. Now there are a few more maneuver we need to do. So this is one of the important signs. Sternberg, I think, na? Sternberg or Sternberg, which one? What is
this
that?
Is thumb sign.
Thumb sign.
Thumb sign.
Thumb sign. So what is then?
The Sternberg sign is when
this,
you are
this one.
This one, yeah, this one. Yeah, exactly.
So sometimes I also got confused with so much of signs. Okay. So this is thumb sign. So usually in normal individual who is not having this hypermobile joint, the thumb sign will be absent because this thumb is extending beyond, I mean, the palmar surface from coming out. Okay. But normally that is not, because of this hypermobile joint, the thumb is flexing more and coming out of the hand. Okay. Now here that is using, so sometimes we in exam sometimes we do with the index finger. This is not with the index finger. Sternberg sign is always from the thumb and the little finger. Okay, so we need to ask the child to can you hold your encircle the hand with thumb and little finger. Then definitely that will be easier if there is hypermobile joint is long, the spider-like hand, which is called spider-like hand, which is called
arachnodactyly.
Arachnodactyly. If arachnodactyly is there, then definitely that will be easier to understand. So this is the examination technique in hypermobile joint. And another part is we need to measure the arm span. So arm span will be longer than the height. This is typical of hypermobile joint. Okay, especially the Marfan syndrome. So this length will be more than height. Okay. So these are the clinical features we need to identify. After that, we will move for the examination part. So this is the basic of hypermobile joint. After that, so here is another picture. As you can see in this picture, how much hypermobile is this little finger? The little finger is touching more than 90 degrees. As you can see here, just touching the opposite. That is very much hypermobile. And here that you can see this is impossible to touch for the normal individual. Here, as you can see in the what's called elbow joint, this much of hyperextension is there, right? More than 10 degrees. Here also more than 10 degrees. So we need to assess according to the scoring system. Bilaterally here, both the side, the scoring will be 2. Here both the side scoring will be 2. Here both the hand again 2. Here 2 and here 1. Total 9. Okay. Total 9. If this is more than 4, definitely the child have hypermobile joint. Okay. So after that, we can say this is hypermobile joint, and we'll just proceed for the next part of examination, that is measuring the upper that is both the limb length, I mean upper limb length, that is total, yeah, and this thumb sign and Sternberg sign. Okay, after that we'll move for the examination of this is the case. Okay.
Dr. Pranab,
yeah.
Sometimes the stamp says examine only general physical examination.
But we need to do this hypermobile. If this child is tall, and you are suspecting, yeah, you are suspecting Marfan syndrome. Definitely, you need to examine the that is our Baton score. Without Baton score, they will be definitely downgraded. No doubt about that, Dr. Naresh. Okay.
No, my this thing. Sometimes the stamp says like examine only the general physical examination. I mean, when you are in the station, this examiner says only do the general physical examination in like a tall stature and a short stature.
Yes.
So once you did the dimensions and you find that this child is a tall or a short, at that point of time, we are supposed to go for the examination of tall stature, or we do the general first and then you go for that?
No. First of all, we need to find out the child is hypermobile or not. Child is having hypermobile joint or not. And after that, general examination.
No. My stamp suppose says this child Rocky, who is a 12 years old boy, just do the general physical examination. This is my stamp.
Yes, okay. You need to do.
No. So once actually we did all the D's, like dysmorphism and my first observation. So when you come to dimension, like the child is now tall, we came to know that the child is a tall or a short. So we have to start from that point, all the this examination regarding tallest or shortest, or where first we do the GP, then we come back to this.
You can do that, but ideally it's better to do this Baton score. Okay, access with the Baton, because this is the clinical science. We need to identify the clinical science. Okay, all these are clinical science. That will be so. What happens in the exam? Basically, they are keeping the marks over the clinical science. So if we are just doing the proper way the examination and picking up the marks, that will be perfect for the examination. Otherwise, if we do unstructured way, first doing the general examination, suppose you are auscultating the heart, that is a part of the examination that can be accepted. But if we are wasting so much of time without doing the better score, they will be definitely downgraded. They will be downgraded. I mean, us basically. Okay. So it's always better to include the Baton score whenever you are studying the examination. Without this scoring system, you can't say the child is having hypermobile joint, and most likely diagnosis is either Mrcpch or Ehlers-Danlos or Baton score is must. Okay. And this is most common exam scenario as well. So never ever to miss this scoring system. Okay, so now we'll just examine, practice over this case. So Mrcpch syndrome, as you can see, that we are not going to say directly this is my Mrcpch syndrome in our exam. So we'll give our DD as this is most likely the child is having hypermobile joint and the tall stature with some syndrome suggestive of Mrcpch syndrome, or my DD is Ehlers-Danlos, and third is homocystinuria. So according to this, the discussion will go on. Okay. So in general examination, after doing this scoring system, we'll move from the hand. General approach is the same for just like other station. Okay, general examination. So we'll start with the hands, then move upward. Okay, move upward up to the face. So start with the hand. What will be the hand feature? Then we'll upward. Then it will check the pulse, and after that we'll check the axilla, and after that all this feature. Then neck, any scar is there. Then face. This is definitely this is high. Mrcpch feature, long faces, and typical feature of Mrcpch syndrome. And after that, we'll just ask the child to open the mouth, and we'll check the oral cavity, including the eyes. We'll check any pallor is there or not. Some less dislocation maybe there, but that will be sometimes difficult to see without using any like instrument. Okay. So after that, we'll check the back. So as you can see, this is hypermobile joint having so much of scoliosis, and there may be sometimes this scar, which is for some of the cardiac operation or cardiac surgery. What kind of complications may be there in case of hypermobile joint?
AR.
Yes, AR.
Aortic dissection.
Aortic dissection sometimes possible. So all these complications may be there. So that's why we will just have an idea that this kind of cases sometimes may be there. That's why these pictures, okay? Now, we'll just practice over this case. This is very, very important case, okay? So, we'll just practice over this one. Anyone interested? We have already discussed the case. Dr. Amma, you have got the seat now. You should come forward.
Hello.
Yes. Just only listening without practice. Okay, and that will be really difficult.
Time?
Yeah, Dr. Nisha, knock me.
Yeah.
So I have entered the room and I have washed my hand, introducing myself. Hello, I am one of the child doctor here in this hospital. Okay. So I will take the permission, and as the child is already exposed, so I will take the permission for the examiner as well as the mother. Can I examine you, Rocky?
Yeah, sure, doctor.
Sure. So, okay, thank you. So, okay, are you going to the school?
Yeah, yes, doctor. Yes.
Okay, which class you are?
I'm in 5th, doctor.
Can you stretch both the hands so I can see your hands, please?
Yeah.
Okay, so I can see there is so much of long fingers, just like features of Arachnoid bacteria, and there is no another bony abnormality here. I will also observe the nails for it kind of pallor or nail features, which like iron deficiency, and blah blah. And after that, I will check the pulse. So, what kind of pulse is this? Is there high volume pulsing pulse is there or not?
Yeah, there is a high volume pulse.
Yes, suddenly I will just check for the watermark pulse as well. I think that will be positive. Then I will move upward and I will check for the signs of puberty in the axilla. So there is no signs of puberty, I think.
Yeah.
And I will just check the neck. Then I will check for any lymph is not there. I can see there is a feces, which is long feces, actually of some syndrome, which is slightly pneumoconiosis. I will ask the child, can you just open up your mouth, please?
Yeah, there is a high-arched palate.
High-arched palate and dentation and
crowding of teeth.
Crowding of teeth, okay. And I will also check the ears and nose and eyes, especially. There may be some dislocation of the lens, which is sometimes is visible but very difficult to see.
Yeah.
So yeah, and now I will just see from the side view for the scoliosis and degree of kyphosis. As I can see, there is scoliosis. The scoliosis is there. At the same time, I will just ask the child, can you bring forward to check the scoliosis is permanent or positional?
It's permanent.
Permanent. Okay, so not desired permanent. And at the same time, I will just come forward. I can see there is some chest deformity as well, and I'm not describing this scar mark over here because this is separate case. Okay, so as I can see there's some chest deformity in form of pectus excavatum or maybe carinatum. That is difficult to say from this picture, but some chest deformity is there. And now I will, if there is any. Okay, so I forgot to do the bill. Okay, can you check? Okay, can you touch with the just this thumb and thumb? I mean, can you hold your thumb with the palm? Basically, that is coming out from the hand or not?
Yeah, that is
thumb
positive.
Sign.
Yeah, thumb sign is positive.
Sternberg sign. Positive.
Yeah, both positive. Wrist sign and thumb sign positive.
Okay. Can you stretch? Can you touch that this thumb to the medial surface? I mean the medial surface. I mean of the radial surface.
Yeah. Hypermobility.
Hypermobility. Can you just fold? Just extend the little finger. That is more than 90 degrees.
Yes.
More than bilateral. Yeah. So I will just ask the child to extend both the hand, laterally to see the elbow joint whether this hypermobility more than 10 degrees is there or not. I think this is positive.
Elbow joint is not hypermobile.
Not hypermobile. Then legs, both the legs and knee joint.
Yeah, there is hypermobility. There is more than 10-degree extension at the knee joints.
Okay, bilateral. Okay, fine.
Yeah.
So there's more than 4, I think. So it will be positive for hypermobile joint. At the same time, I can see in the foot there is some degree of flat foot which is present.
Yes.
And yes, and if there is time, I will also auscultate the heart because some normal may be there of our technical. And that completes my examination, I think.
Yeah.
And if there is time, I can also check the gate if there is time. Okay.
Yeah. Would you like to do any other examination?
Any other examination?
To complete your examination, would you like to do anything else?
Yes, I definitely I will put the child on a age-appropriate growth chart, and I will also check the arm span because the arm span is longer than the height. Okay, so that's why arm span is needed. And also I will do some pulmonary function test, but if this is the scoliosis. So
yes.
So is this completed within time, Dr. Nisha? Where you are?
Yeah, 1 minute left.
Oh my God.
You can check the blood pressure too.
Yeah, blood, if there's time, I'll also check for the blood pressure, and if there is any signs of heart failure, so I will also check the liver as well. So auscultation of the heart is more.
These measurements we can do at the time when we mention dimensions. We can.
Yeah, we can do at the time of dimension. We can do at the beginning also. So there is no problem, but we should not miss what I have to say. So I will also look towards the parent basically. So is there any kind of parent, the similar finding is there or not? Because this is autonomous domain. Now the question answer part. I have examined a 12-year-old child, Rocky, and a few striking features of scoliosis and tall stature with syndrome, which is a history of Marfan syndrome, and there's a high volume collapsing pulse and arachnodactyly strand of positive and Brighton stone more than 4, which is a history of hypermobile joint, including this scoliosis. So together, all this finding, this is most likely diagnosis of my first DD will be Marfan syndrome, and second is Ehlers-Danlos syndrome. Both are autosomal dominant, and third is homocystinuria, which is very unlikely in this case. The next part of question, please.
How will you investigate this patient?
Okay, so investigation part, this can be divided into 2. If this is already diagnosed, then no diagnostic test is needed, but I will look for the complications as a part of here. I will just involve the eye doctor for eye checkup, and after that cardiologist for echocardiography for the condition of the heart, what kind of lesion is there, with most likely aortic lesion. I will need the orthopedics to assessment the degree of scoliosis, if there is any respiratory difficulty, spirometry, and some Pope's angle measurement. And after that, I will also see the basic line blood test to see any kind of pallor is there or not, renal function, liver function, and some calcium, and I mean the metabolic bone disease, and all this, calcium, hospital, blah, blah, blah. All these things, including the creatinine.
Will you prescribe any medicines for this child?
Okay, so if there is signs of any cardiac complications, then definitely I think beta blocker will be helpful.
Yeah, very good.
And
what advice will you give to the parents?
So definitely my first advice would be, this is a genetic condition, so you need to counsel with the genetic counselor for the next pregnancy. And the second thing, will just avoid the strenuous exercise that can be complicated with aortic dissection as well. And third, for regular follow-up for eye checkup, as well as this cardiologist follow-up.
And avoid lifting heavy weights.
Weights. The thing. If I am
3 minutes, Dr. Nisha, 3 minutes over.
Yeah.
So these are the typical types of questions that will be asked in the examination, what Dr. Deepa asked today. So in this way, we need to...
Dr. Pranab, did you complete the 4DSP as such initially?
4DSP already it's covered, because whenever I entered the room, the child is already dysmorphic. Growth I mentioned in the last.
You mentioned growth, but devices you not mentioned, and surrounding as well.
Yeah, but most likely there was no device. Actually, I have prepared the slide, that's why I have not asked. But definitely, after entering the room, that will be very much prominent for everyone, right? So that's why maybe I forgot, or maybe I...
yeah, just I think you mentally rehearsed through that part because there was it's okay.
Yeah,
it's okay.
Yeah. You later on mentioned everything one by one, but not initially. You didn't.
Initially,
but that is what happens actually. No, what we see in the surrounding, we don't mention in real exam. That is, But we shouldn't. If we don't ask the examiner, we won't know that. So that's why we are mentioning it here.
We might forget it later.
Yeah.
Like parents, you said later. So we might forget it if we don't mention it initially.
Yes,
and you didn't say upper limb, lower limb ratio. Did you?
Arm span height ratio, he mentioned arm span.
Arm span is important. Upper limb, lower limb ratio is short stature. That is more important than short stature.
Arm span.
Dr. Pranab, did you examine cardiac?
Yes.
I examined.
Yeah.
Okay. Sorry, maybe I missed it. But in summary, like, did you mention it?
Summary, if I got any finding, that will be included in my summary. So in online, how can I interpret? Most likely there will be aortic regurg.
Because there was water hammer pulse, I thought there would have been some finding.
Finding, that is not important. That's why if the task is do the cardiovascular examination in the similar patient, the same patient, at that time cardiac finding is definitely important. So if we miss any murmur in general examination, then sometimes that can be that can.
But I also have another. Yeah, even in our CVS station, we discussed about Marfan's, right? So how will the stem be given? Will they mention that examine this case of Marfan's, or like, because if it is CVS examination, we will not have time for weight and score and all.
No, CVS CVS examination, if the task is do the CVS examination, okay, so then CVS examination itself, that will take time. So the weight and scoring is not included over there. So if the task is general examination, then weight and score is mandatory. Okay. That is very important exam scenario. Okay. Some of the children may have specs. Okay, for this lens this location. Okay, guys. So we'll any other feedback? Otherwise, I'll move for the next few more important cases are there. No. Yeah. The opening statement is Akshay, who is 12 years boy, kindly examine the spine.
Yeah, can I do that?
Yes.
Yes, just give me 1 minute, okay?
Sure. Okay.
Okay.
Just the time.
Yeah.
Okay. So your time starts now, please.
Yeah, I'm entering the room. I'm handing over my papers to the examiner. Good evening, sir. I am greeting Akshay.
Good evening.
Good evening, Akshay. I am here to examine you. Is it okay? I'm Dr. Deepa, one of the doctors here.
Yes, doctor, please.
Yeah, I'm. Are you going to school, Akshay?
Yes, yes.
Yeah. Okay, so I'm looking at him. I can see that there is a grossly deformed thoracic part. Other than that, on the face, I don't see any dysmorphic features. There is asymmetry on the thoracic part. Otherwise, there is nothing. Is he well grown for his age? I would like to plot him on a weight and height on a chart.
Not well grown.
Not well grown. Okay. So I'm looking at him for, I can see that his upper limbs are wasted very much and back is also wasted. I'm looking for any neurocutaneous markers anywhere.
No.
I'm looking for any scars on his upper limbs or lower limbs, spine, everywhere.
No, no scar.
No scars. Can you just walk for me, Akshay? I'm looking at his gait.
Okay, so gait is near normal, but upper part, as this, there is scoliosis.
Yeah.
That is the only finding.
Is there any foot deformity for him? Any pescavers or
no.
Nothing? Okay. So I would like to measure his limb length lower limb for limb length discrepancy later. And now I'm going for examining his hands. Is there anything abnormal in his hands?
No, in the hands there is nothing.
No arachnodactyly or long fingers or any abnormal markings?
No.
Nails?
No.
Everything is normal. I'm looking at his eyes for any changes. No. Can you just open your mouth for me, Akshay?
Yeah, there is no high palate. Nothing is there.
Yeah. Now I'm going for the examination of the spine. I'm looking at him from sides and back. I can see that there is a gross scoliosis in the thoracic region towards the right side, and the right scapula is elevated, and there is increased space between the left arm and the thorax. Okay, now I am just palpating his spine for any hemivertebrae or any swelling.
Nothing.
Or any increased temperature.
Nothing.
Is there any tenderness? Actually, I'm going to touch you. If you have got any pain, just let me know. Okay.
Okay.
I am palpating his spine one by one. Is there any pain?
No.
No, I'm just auscultating the apex of his curvature, the scoliosis curvature. Okay. Is there any buoy or anything?
None.
Now, I'm going to do some manuals. Can you just bend down and touch your toes?
Yes, there is no disappearance of this phase that is persistent.
Okay. Can you bend backwards like this? Is he able to do backward bending of the spine?
Okay, that is painful.
Yeah. And is he able to do lateral bending on both sides?
Yeah, the movement is restricted in the right side. Okay. Left side is bent laterally, but right side there is restriction. Okay.
Okay.
This side movement is restricted.
Left side is normal, right side is difficult. Yeah.
Yes.
Actually, can you sit down on the chair? I am just reevaluating the curve. Is there any change when he sits down?
Okay. No, the curve is persistent. There is no change.
Can you rotate to both sides? I am demonstrating him. Just rotation to both sides.
Lateral rotation, right?
Lateral rotation, yeah.
Lateral rotation in the right, which is called in the left side, that is normal. He is but in the right side, there is difficult to rotate.
I'm just actually I'm trying to lift you up. If you have pain, just let me know. I'm holding him under the axilla from the back and trying to lift him up. I'm seeing if there are any mobile component to the scoliosis that may disappear with the lifting up.
No.
Is there any change to the scoliosis happening when I lift him up under the axilla?
No.
Yeah. Then Yeah, now I have completed the examination of the scoliosis. Now I would like to do a neurological examination of his upper limbs and lower limbs if time permits, and a CVS and respiratory examination to know the impact of the scoliosis. I am just auscultating his heart. Is there any loud second heart sound is there?
Yes, yes, right.
Yes. Yeah, I'm auscultating his, is there any murmurs?
So there is no murmur.
Yeah, I'm auscultating his lung fields for air entry. Is it normal bilateral?
Air entry, yes, there is some crepitations over the right side. Yes, yes.
Okay. I would like to plot his height and weight on age-appropriate chart, measure him for subcutaneous fat because he is very emaciated. I would like to check his PEFR and record his vitals, including his blood pressure.
Yes.
And that would complete my examination.
6 minutes, just 6 minutes. Okay. Yeah. So the thing is, okay, the examination part, I will just come to the
yeah, happy birthday. Yeah.
Puberty is very important. Okay.
Yeah, yes, yes.
So now I will just okay. So what are the investigations you want to do for this child? What are the DDs? First of all, what are the DDs? Present your case and what are the DDs?
Today I have examined 12-year-old boy Akshay who doesn't look well grown for his age, and there is a severe scoliosis of his thoracic spine towards the right side, which is compromising his lung functions and causing a restrictive lung disease, which is evidenced by evidence of pulmonary hypertension and basal crepes on the lung fields. And there is no neurocutaneous markers, and his rest of his systems appear to be normal. So I think this is a structural scoliosis, which needs further evaluation with X-ray of the spine.
Okay. Okay, fine. So what are the other skeletal deformity, I mean, skeletal dysplasia or skeletal reason, maybe the syndrome which is associated with this scoliosis?
It can be a part of syndromes like neurofibromatosis or other neuromuscular disorders like maybe cerebral palsy or Duchenne muscular dystrophy or spinal muscular atrophy. Anything can cause
Yes.
this. And skeletal dysplasias like osteogenesis imperfecta.
Yes. So what are the investigation you want to do?
For this child, first of all, I would like to do an X-ray of the spine to assess the corpse angle. If it is more than 45 degrees, surgery is indicated. Then I would like to do a CT or MRI to assess the spinal column, to the spinal canal, and to rule out spinal tumors, if any, may be causing this problem, or any spinal cord abnormalities like syringomyelia or anything. And because his cardiovascular system is involved, I would like to include the cardiologist in his evaluation, and I would like to do an echocardiogram. And respiratory physician should also involve in his care, doing his spirometry to assess the severity of his restrictive lung disease. Okay. And for his general malnutrition and growth failure, I would like to do the basic investigations, including a full blood count, his renal and liver function tests, and his vitamin levels and ferritin and everything.
So how you will manage this child?
This child needs a multidisciplinary approach because his kyphosis is causing his growth restriction and cardiovascular and pulmonary involvement. I would include my consultant, cardiologist, respiratory physician, dietitian, orthopedic surgeon, and orthotist, and a physiotherapist. for his management.
So if this degree of scoliosis, that is Pope's angle, as you mentioned, which is near about 20 to 40, then what is the management?
If it is 20 to 40, the orthopedic surgeon will evaluate him, and he can have a spinal rod inserted through a surgery to prevent.
No, that is an operation.
That is a surgical correction.
That can be managed conservatively with bracing.
Bracing. Yeah, yes. Sorry.
So,
because he is about to begin his pubertal growth spurt, this scoliosis may worsen suddenly. So he needs close follow-up by the orthopedic surgeon and regular assessment of the corpse angle loads. What
are the complications this child may have in future if left untreated?
Yeah, if left untreated, most commonly he may have cardiovascular involvement because of pulmonary hypertension, and restrictive lung disease may be progressive, and he may have severe restriction of his mobility, and his lower limb neurological function may also deteriorate later.
Yes.
Because of the cord tethering.
Exactly. So that is one of the red flags I need to tell to the mother. That is bladder bowel involvement may occur due to some cord compression. Okay. Pain in one of the complications, pain. Then systemic involvement, just like you said. Okay, that is sometimes restrictive lung disease with obstructive sleep apnea, and sometimes respiratory failure, sometimes left ventricular failure due to pulmonary or pulmonary hypertension, as mentioned. After that, some psychological issue may be there because of this scoliosis. So all these are complications. So that treat accordingly. Follow-up is very much important. And okay, management you said, right?
Yeah.
So these are the part of discussion, I think. Anything we left, because I will just move for the examination part. Okay, because I think what we have just discussed during our first beginning of this discussion. We need to divide the spine. If the task is spine examination, definitely as you are going just like examination, that was absolutely fine. That is, look, first of all, you already observed. After that, feel. So feel part means we need to assess this spine, not only over the spine as well as parallelly. Just like in both the sides, whether any kind of hotness or coldness or any kind of temperature is there or not, or any pain is there or not. With the press over this side, this is the part of look, feel, okay, feel. After that, we need to look, feel, then move. So move means we need to divide the spine into 3 different quadrants. Number 1, cervical. Number 2, that is thoracic, and thoracolumbar. This 3 part. Cervical, you need to check the cervical movement. Just like here in the cervix, there is 4 cervical area, 4 movement in the spine. Have you checked, Dr. Deepa, in this way?
No, I missed the cervical area. And
that's why this is unstructured. Okay.
Yeah.
So here, cervical there. Okay, let me just open the structure. I think that will be helpful. Okay, here as you can see, if the task is spine examination, so I have made this lower limb spine. Here is the spine. So look, 6 movement in the cervical. Look, feel, move, and function. So 6 movement in the cervical spine. Put the chin on it. That is flexion of the neck. Okay, in the cervical area, and look up at the ceiling. That is the extension, and look over the shoulder. That is lateral rotation, both the side. Okay. both the side if he is moving, then there will be two movement. And put the ear bilaterally, that is lateral flexion. Lateral flexion, that is also 2. Okay, so 2, 2, 2, and 1, 1. So total 6 movement here. Got my point? Are you getting me, guys?
Yes.
So here in the cervical spine, any joint may be, there may be painful joints. So 6 movement in the cervical spine. In the thoracic spine, there is 4 movement again. That is flexion, extension, lateral flexion, and lateral rotation. That is thoracic. And lumbosacral, again, forward, that is flexion, extension, again, lateral flexion, lateral extension, and rotation. Rotation is the movement, that is lateral rotation. Rotation movement in the thoracoalveolar spine just only possible. So that's why left side and right side, both the side, we need to check this rotation. And you check the gait. That is the approach in spine examination. Okay. Otherwise, definitely they will just deduct the mark.
Yeah. Spine includes cervical spine also.
Yes.
So do you have to include the temporomandibular joint in the spine examination?
If you, that is, I have not got any book who is mentioning this temporomandibular joint, except that of if you are suspecting some arthritis group of,
I heard once in a meeting that it is part of the cervical spine, this temporomandibular joint also. I'm not sure of that. Yeah.
If there is time, then you can do that.
1 second, sorry to interrupt. But I did watch that video of Greeky videos, but they whatever you say about cervical spine, they did the 6 movements. In lumbar spine, they do the 3 movements: flexion, extension, lateral flexion. And thoracic spine, only thoracic rotation. So why did I get all the movements in which video? And they do the Scovas test.
Scovas?
You have to identify. You have to bend down and touch your toes and make the distance. That is SCHOBER, Scovas test.
I really forgot from which book I have taken this piece of information. But this is mostly from Mrcpch or some other books. I forgot that.
In spine examination, you have to do the straight leg rising test and Scovas test. That's must.
Leg rising?
A straight leg rise test. Or sciatica.
What?
It's sciatica, when a pain in the posterior thigh or hip. That suggests sciatica. And
okay, that part I really don't know, but I will just have another look, so that if I am missing that, I will just add on. Okay, but spine is important.
Oh, yes, sir.
Okay.
Dr. Abhishek, can you please post those 2 tests in the group?
Yeah, you can
so
post
we
it
can
in
all
the
search
group.
maybe.
Yeah, definitely. We need to know, because cervical, the spine examination is one of the exam case, important exam case. Okay. Okay, not here actually. In the group. Okay, guys. So we can move for the next one. Another important, which is, so what is this syndrome? Can anybody suggest what is this syndrome?
People fail.
So one of the center, they are keeping this case. People fail. So again, so what is the importance of this kind of cases in the exam? So if there is any abnormality, so this is basically there is fusion of cervical spine with this, and then the short neck. Okay, so all the movement in the cervical spine will be restricted. Movement will be restricted. So we need to find out clinically what are the movement are basically restricted. So that is the key to pass the exam. After that, there's at the same time some degree of movement in the shoulder joint is sometimes also may be restricted. So we need to examine this. If the task is thus just do the spine examination. Sometimes related joint is here, fusion will be there. So that will be dependent on the case, not classical, just like spine examination. And few other features which people feel will be there. And here, what is this case? This is also given in one of the exams. This child, What is this case?
Scapulohumeral dystrophy, is it?
Possible. Mostly this is
Scapular webbing sign used for this Duchenne muscular dystrophy.
Duchenne.
Yeah, I think so. That's for the
No,
scapular, this thing.
no.
Winging of scapula. Winging of,
That is
not that
different.
one.
No. That is different. This is springal anomaly. That is springal anomaly. Okay, that can be corrected. So here the addition of the muscle will be released, and the post of surgery, as you can see, this is the result of after surgery. So they will just open up from here and release the tendon, which is attached with the just muscle and the muscle releasing. So this is a springal anomaly that is given in also movement over the shoulder joint will be restricted. As you can see, the child is when we are doing the pig health now. At that time, the child will be unable to just just keep the hand. I mean, put the hand in just like upward. Okay, that movements will be shoulder joint will be restricted. Not only that, internal rotation, then external rotation, and flexion, adduction, every movement will be restricted there. That is a clinical finding. You need to find out. So that is another type of case that is given in the exam. Okay, and here is another springal anomaly, as you can see here. I'm not going to detail a springal, that will be very much less. Here another triple fail. As you can see, there is, in the X-ray there is fusion of the cervical spine. That is a typical finding in the X-ray. X-ray finding there will be fusion, and that's why neck movement, total cervical area, every movement, mostly lateral flexion, lateral and rotation and extension, mostly every movement will be restricted here. That is one of the examples. And
Pranav, that springal anomaly is a part of Poland syndrome, isn't it? Poland Mobius.
No. Poland is different. That is absent of petrolus major.
I think that anomaly is associated with that.
Maybe associated. Maybe there may be sometimes absent of this petrolus major. Okay. So we'll just practice the common cases. So here is our next case. Okay.
Dr. Pranav, for that springal anomaly, Klippel-Field anomaly, what would be the common questions they can ask?
So if after diagnosis, they will be asking the DD. So after DD, they'll be asking what are the investigation you want. Okay, clinical science you need to describe. What are the movement restricted, whether any wasting is there or deformity is there. All these findings are important. And after that, they will ask for the investigations. What are the investigations? So mostly this is X-ray and sometimes MRI and CT scan. Okay, so after that, they will ask, okay, how will you manage this? So mostly this is orthopedic case. They will manage this case because the child is clinically stable. And if there is any other association, according to this, including the complication, we will manage. Okay.
So we have to read these syndromes little.
Yes, definitely. And here is our next important, most common exam case. So we'll just practice this case. Okay, anyone who have not actively participating and got the seat, just can practice.
Oh, what is the? Hello.
Yeah.
Hello.
Yes.
May I do that? But
yes, the task is this is 7 years old child, Monica. Okay, now let me write it down. 7 years. Okay, so your time start this one. Time starts now.
I have entered the room and hand over my exam sheet to the examiner, and I am doing the hand hygiene. From mother, I am Dr. Abhishek, one of the candidates today. May I examine Monica?
Yes, please.
Hello, Monica. Do you go to school?
Yes.
Hello, how many
Okay.
friends you have?
4.
I am closely looking at Monica, and I see that he seems to be small for his age, and I would like to plot her on age-appropriate growth chart. I think he is not looking sick. Is he looking sick?
No.
Okay, then I am looking for any obvious dysmorphic features. I am not getting, I think, any dysmorphic features. And
No.
hearing aid or visual no spectacles or any
No.
IV cannula mark or anything.
No.
And now I am closely looking at Monica from front, and I can see her muscle is wasting, and see and there is widening of the both wrist joint, and on the legs there is genu valgum deformity, and there is no knee present, and then I am looking for any rashes and any kind of neurocutaneous markers. Okay, from front, and I am inspecting him from the side and as well as the back, and I'm looking to the from the back for any scoliosis or any kyphosis.
Okay. Some degree of no, okay, nothing is there.
Nothing is there. I can in the then I'm looking at the hand and ask him to show my hand like this, and I'm looking for any pallor, or is there any obvious clubbing,
No.
any cerebral cyanosis or not. Then I'm just checking this joint. Is there any tenderness present or not?
Okay. Joint tenderness is not there.
Okay. Then I'm uh, ask her to do like this, to check for the pallor. I'm
Yeah.
checking her pallor,
Slight pallor is there clinically. Nothing more.
and I'm also doing a test for the jaundice, looking ask the child to look at his feet and raising the seeing the upper bulbar conjunctiva for jaundice.
You are suspecting leakage, so why you are looking for jaundice?
If
Okay.
my examination is generally, then I think I
Okay,
need to check
fine,
all
fine. No,
general
no
parameters.
jaundice, no jaundice. Okay.
Okay. Then I cannot see any. I cannot see his face. Is there any frontal bossing present or not?
Yes,
I'm not
there,
able to see.
there.
Yes. Then I am okay. Then I am looking at her. I ask her to open her mouth and see her dentation.
Okay. So dentation is poor. I mean, crowding and carries it
Is
there.
there any delayed?
Not mal
Okay.
dentation.
Okay. And I also in the skull I am looking for any soft skull, uh, any delayed fontanel closure for craniotabes.
Okay, Fontanelli is closed, but craniotabs is there. Yeah.
Okay, I'm checking the in the chest. I am getting that there is a costochondral junction is prominent. So there is a swelling of the costochondral junction, that is hepatic rotary is present. And I am now asked her for I will ask her for checking the Gower sign.
Okay. So the trend negative.
Okay. Monica, can you please walk for me?
Yes, the walking and touching both the knees that is difficult to walk, as you can see.
Okay, Monica, I am at the child's level and seeing the gate. Is there any kind of other any waddling gate or any other kind of gate?
Waddling is just for this, knock knee only.
Okay, and then I am looking for 2 minutes. That's it. Uh, uh, then I asked her to walk on your in your tiptoe.
Okay.
Hello.
Yeah, she is walking.
Okay. And is there any problem other than this?
No.
Now, Monica, will you sit in the couch for me?
Yes.
I am closely looking at both legs and seeing that is there any muscle wasting. I can see there is muscle wasting is present, and I am looking for the leg length discrepancy, limb length discrepancy.
Okay, very good. So there is slight of no discrepancy. No.
Next, I will do the hip joint movements. I will do the 6 movements of the hip joint, like adduction, flexion, extension, internal rotation, external rotation, adduction, abduction, to
No,
see
no,
any
no, fine.
restriction of the
No,
movement.
no, no, no.
I am doing the knee joint flexion and extension. The
There is no restriction of the movement, but hyperextension is there at the level of knee joint. As you can see, the left side and right side, there is also bit hyperextension that is making child knock knee.
Then I'm checking the ankle joints, any kind of swelling, if you can is present or not, and then doing
Time
the
out.
movements of plant.
Negative. Nothing is there in the ankle joint.
Okay.
Present your case.
So today I have examined. Okay. Today I have examined 7 all for his age. I would like to plot her on age appropriate growth chart. She is well in himself, her sitting comfortably at rest. So there is my positive findings are there is a wrist joint swelling in both wrist joint. There is some swelling, uh, and there is a frontal bothing. There is poor dentition. There is a retitic rosary present, along with there's a genu valgum kind of deformity, and the joint movements were unremarkable, and rest of my movements are unremarkable. So my provisional diagnosis may be a case of ricket.
Okay, ricket, there are several varieties. Which ricket? What type of ricket?
Most probably it is the case of vitamin D deficient ricket. It may be X-linked hypophosphatic ricket. That is less chance because maybe vitamin D deficient VDDR type 1 and VDDR vitamin D dependent ricket type 1 or VDDR type 2.
Okay. So these are the type, but where exactly which type of you are suspecting here?
Actually we to do it may be chronic kidney disease, it may be renal tubular acidosis that may lead to ricket or chronic kidney.
No, I'm asking for this child. This is, as you said, this is most likely
vitamin D deficiency ricket. Most probably.
Okay, yes. As you can see in different types of ricket, what are the other types you mentioned, and what will be the other clinical features? Can you elaborate? In your DD? In your DD?
Ricket, what are the, sorry, I can't get your point. What? Sorry? In your
suppose you are saying this is VDDR 1 and VDDR 2. What the abnormality happens in this two?
Yes. Okay. If it is case of VDDR type 1 or VDDR type 2, usually we have to check the phosphate first. If we get the phosphate is high, then it is showing metabolic acidosis. Then it is the case of renal tubular acidosis. Then
okay, not. I'm not asking about the investigation. I say, what is the type of defect in VDDR 1? What is the type of defect in VDDR 2?
VGA type 1, there's an enzyme defect. There's an enzyme defect called 1-alpha hydroxylase. So that is in the liver. So that is so what there is 25 hydroxy between these three is more, and 125 dihydroxycholecalciferol is less. Whereas in case of VDDR type 2, there's an end organ resistant to the 125 dihydroxycholecalciferol. So that level is raised. 125 dihydroxycholecalciferol is raised. I don't know if there are any clinical signs are there from that. I don't know.
Yes, definitely. Because type 2, there will be some more clinical finding. I will discuss the type 2 in the later part. Okay. So what are the other types as you mentioned in your types? So in exam case, if the child is smaller age group, that is most likely one of these, maybe vitamin D deficiency or maybe this autosomal recessive variety of vitamin D, depending VDDR1 or VDDR2. But if the child is older age group, most likely there will be bowing of leg, and if there is any other parent which is there having a similar kind of features with bowing of the leg, then most likely you are dealing with autosomal, X-linked vitamin D resistant ricket. Okay, that is the key basically. Yeah. So what will happen in like in autosomal, not autosomal, hypophosphatemic ricket, that is the bowing of the leg will be mostly there, and that will be prominent both in the child as well as some of the parent. Some of the parent there will be this kind of bowing of the leg. So we can suspect that is hypophosphatemic ricket. The degree of bowing of the leg. Okay. Now, how you will manage this child quickly? Are you there, Abhishek? I think left. Okay, he's there.
Involve team involving dietitian, pediatrician, and hello.
Yes.
Hello.
Yes.
We will give him vitamin D supplementation. Hello.
Yes.
Am I audible?
Yes. Yes.
Okay. We'll give him vitamin D supplementation along with calcium, phosphate, and I will recommend him to expose to the sunlight and some vitamin D fortified foods like mushroom, egg yolks, or meats.
Okay. Okay. If you have got a case of vitamin D resistant ricket or hypophosphatemic, then how will you manage this child?
I will take I'll involve the consultant along with the specialist opinion, and I will then give him the juice solution that is 30.4 mg per phosphate per ml. So we'll have to give the juice solution along with we have to give the calcium.
What is the most common complication of phosphate you are giving in orally? High dose of phosphate. If you are giving phosphate orally in high dose, what may be the most common complications?
I don't know.
Suggest. Very, very easy. Have you used phosphate ever in hospitals?
Never used this X-linked.
No,
I have given juice solution, but
we have read it theoretically, and we have got the result as well whenever we are using. So that is most common complication is diarrhea. So if you are giving high amount of phosphate, it will be lose motion. Okay. Okay. Then. Okay, so this the discussion. Any other thing that hit high dose of phosphate and with bisphosphonate, right?
Okay.
Okay, I think these are the discussion part, and the rest of the part, I think we can go to the books with different type of books to cover the theoretical part. Okay. So what maybe the complications if left untreated, that is short stitches, skeletal deformity, fractures, and dental malocclusions. Okay, these are the complications. And what are the other conditions where you can get these craniotabs? If there is craniotab, then what are the other conditions where this kind of similar craniotab will be prominent? One is massive hydrocephalus patients. Then rickets we already discussed. Some cases of osteogenesis imperfecta, some syphilis, congenital infection. Okay. And yes, these are the part of discussion, guys, and rest of the thing we cover up with the theoretical part. Okay. I think if we read after this session, that will be more easier gradually with repeated discussion and repeated practice. Okay. Now we'll move for our last case tonight. This one. Maria, 14 years old girl, kindly examine the lower limb MSK. Dr. Star, there is someone in our group, Dr. Star.